Next, let's discuss liver anatomy. This is pretty complicated anatomy, so let's work through it systematically. Individual hepatocytes have two surfaces, an apical surface, which faces the bile caniculi, as well as a basolateral surface, which faces the sinusoids. The sinusoids are a network of low-pressure vessels composed of fenestrated endothelial cells. These drain to the central vein, which then turns into the hepatic vein. Blood flow comes from the outside of the lobule through the hepatic artery and the portal vein, and it feeds centrally into the central vein, which then leaves the liver through the hepatic vein. The hepatic portal vein, which you can see here, brings in the majority of the blood supply and comes from the venous drainage of the GI tract. Hence, it's nutrient-rich but oxygen-low. The hepatic artery supplies the oxygen-rich blood and thereby supports the hepatocytes and other liver cells. The blood then flows through this network of hepatocytes and ends up at the central vein. Bile, on the other hand, flows in the opposite direction. Here, the bile goes through from the hepatocytes out towards the bile ducts, and as it leaves the hepatocytes through the apical surface, it flows through the bile caniculi and into the bile ductules at the ends. Given this anatomy, different zones of the liver are affected in different ways by different insults. Zone 1 is the zone around the portal vein, which you can see here. This zone is most affected by viral hepatitis and ingested toxins. This makes the most sense as blood carrying the virus will hit these cells first. The next zone, Zone 2, is the intermediate zone. Zone 3 is the pericentral zone. Since blood flows from out to in, it's not surprising that blood flow reaches this part last. So in situations where ischemia occurs, the central zone will receive blood flow last and will therefore be most sensitive to anoxic injury. This zone also contains the P450 system, making it the site of possible toxic injury. It is also the main site affected by alcoholic hepatitis. Let's now do a flash quiz to cement what we've just learned. A patient presents with jaundice, encephalopathy, and oliguria. He has elevated liver enzymes with a history of alcoholism. What zone of his liver is most likely affected? That's right, it's Zone 3. Remember, Zone 3 is also known as the pericentral vein zone, and since it contains the P450 system, it makes it really susceptible to toxic injury, especially alcohol. Alright, we have covered a lot of the abdomen, but we still need to mention the gallbladder and related biliary structures. Let's get oriented to the diagram. Here we have the gallbladder, the duodenum, and the pancreas. Okay, so what is the path of the bile? Well, the bile that is produced in the liver exits via the right and left hepatic duct, which merge to form the common hepatic duct, which you can see here. Some bile travels up the cystic duct, which is here, for storage into the gallbladder. And bile also travels out of the gallbladder via the same cystic duct, at which point the channel is known as the common bile duct, which is seen here. The common bile duct travels inferiorly through the pancreas and combines at some point with the pancreatic duct, which carries pancreatic secretions. These two ducts merge and empty their contents into the duodenum through two regions with very special names. The ampulla of Vater, which refers to the duct lumen, and the sphincter of Oddi, which controls the opening and closing of the duct. When you think about gallstones, it is important to know at what point in the duct system the stone or stones are obstructing. This is tested on the exam. In some cases, they can reach the ampulla before getting stuck, and there they would block both the biliary and the pancreatic ducts. Tumors can also arise in this region, pancreatic cancer being the most typical example, and this can cause an obstruction that eventually leads to the classic sign of obstructive jaundice. What do we call the situation where a gallstone is obstructing the common bile duct? This is cholecystolithiasis. We'll next review the femoral region very briefly. The key mnemonic here is navel, N-A-V-E-L. This tells you the lateral to medial structure of the femoral region. The femoral nerve is most lateral, and as you move medially, you encounter the femoral artery, femoral vein, a gap for empty space, and then the lymphatic vessels. Here we can see both a cartoon version as well as a gross specimen. What is the femoral triangle? Well, the femoral triangle is bounded superiorly by the inguinal ligament, medially by the adductor longus muscle, and laterally by the sartorius muscle. This triangle contains the femoral vein, artery, and nerve. The femoral sheath is a tube below the inguinal ligament that contains the femoral vein and artery, as well as the canal, but does not contain the femoral nerve. Now, let's do a flash quiz. What femoral triangle structure lies outside of the femoral sheath? That's right, it's the femoral nerve. Again, this is really important to remember. Let's go over the inguinal canal. This is a diagram that provides a detailed view of the inguinal region. We should first get oriented to the diagram. The internal abdominal wall is here at the top of the diagram. The skin, which is not shown, would be at the bottom, and we have medial on the right and lateral on the left. From outside to inside, what are the layers? Well, the layers are the skin and the fascia, which are not shown, and then the external oblique muscle, which you can see here, the internal oblique muscle, the transversus abdominis muscle, transversalis fascia, and then the peritoneum. Remember that the peritoneum has two layers. The parietal peritoneum is attached to the abdominal wall, and then the internal visceral peritoneum is attached to the organs, which isn't shown here. The main advantage of this diagram is that you can really see where specifically the spermatic cord travels and use this to understand the two main types of hernias. The spermatic cord, which is only about 4 centimeters long, travels inferomedially and acquires coverings from various abdominal wall layers. You can see here that these layers are the internal spermatic fascia, the cremasteric muscle and fascia, and the external spermatic fascia. The external spermatic fascia, which is added last, comes from the external oblique muscle. The cremasteric muscle and fascia are from the internal oblique muscle, and the internal spermatic fascia is from the transversalis fascia. If a region of intestine protrudes through the internal inguinal ring, this is considered an indirect hernia, which we're going to go over more later. However, if the ring and cord are not involved and the hernia instead protrudes right through the abdominal wall, this is considered a direct hernia. You can also see that the direct hernia, which would be located here, would occur medial to the inferior epigastric vessels, while an indirect hernia, which would occur in this location, occurs laterally to the inferior epigastric vessels. Next, we'll review the 4 types of hernias in more detail, as this is a very high-yield topic for the exam. A hernia, as you know, is simply a protrusion of peritoneum through an opening, and the hernias we are interested in are indirect and direct inguinal hernias, which we just mentioned, as well as diaphragmatic hernias and femoral hernias. These can all be seen here. Now, let's go into more detail. Again, the indirect inguinal hernia goes through the internal inguinal ring. And after passing through the spermatic cord and external inguinal ring, it goes into the scrotum. This occurs lateral to the inferior epigastrix, which we just discussed. In infants, it can occur if the processus vaginalis fails to close. The direct inguinal hernia goes right through the abdominal wall, medial to the inferior epigastrix. What is this area called? This area is known as Hasselbalch triangle. Direct hernias do not pass through the internal inguinal ring, but instead they go through the external inguinal ring. The direct hernias are commonly thought to be associated with congenital weakness in the abdominal wall or heavy lifting or exertion, but study results are mixed. One mnemonic you can use to remember the difference is MDs don't lie. This reminds you that medial to the inferior epigastrix is direct, while lateral to the inferior epigastric is indirect. Two other important hernias are the diaphragmatic hernia and the femoral hernia. A hernia that occurs in the diaphragm allows abdominal structures to enter the thorax, and if the opening is large enough during fetal development, this can impact lung development. What is the most typical type? Well, hiatal hernias are the most typical type of diaphragmatic hernia, and here the stomach herniates through the esophageal hiatus into the thorax. Sliding hiatal hernias are the most common subtype, where the gastroesophageal junction is displaced. Paraesophageal hernias can also occur with a normal GE junction, and the cardia of the stomach is displaced into the thorax. The final hernia to mention is the femoral hernia, which you can see here. This is more common in women. Here, there is a protrusion below the inguinal ligament and through the femoral canal, and this is an important cause of bowel incarceration. This diagram also provides a broader view of the region of interest, showing us the critical inferior epigastric vessels and the sites of the different hernias. You can see that the Hasselbalch triangle is formed from the inferior epigastrix, shown here, the lateral border of the rectus abdominis, and the inguinal ligament. Let's now do a board-style question to wrap up the anatomy section. A newborn boy is brought to his physician's office by his mother, who reports that the baby is constantly crying and that his scrotum seems much bigger than it was at birth, just 2 days ago. The physician suspects that the child is suffering from a hernia. The baby's scrotal swelling is most likely the result of what kind of hernia? Is it A, a diaphragmatic hernia, B, a direct inguinal hernia, C, a femoral hernia, or D, an indirect inguinal hernia? Well, that's right. It's D, an indirect inguinal hernia. Remember, indirect inguinal hernias most often occur in newborn male infants. In this case, the peritoneum goes through the internal inguinal ring and enters the scrotum because of the failure of the processus vaginalis to close. An indirect inguinal hernia passes lateral to the inferior epigastric artery. Well, this concludes GI anatomy.